Hi everybody, thanks for joining us today for our seminar series, Dr. Stutz, and he's a professor of medical oncology here. He is the scientific director of behavioural oncology, and he also serves as the co-lead for the Cancer Prevention and Control Program and co-director of the Population Health Shared Resource for the Cancer Centre also. He has a long history of funded research looking at lung cancer outcomes and has won an award actually from Kentucky for helping survivorship of cancer patients in Kentucky. So with that, I want to turn the time over to Dr. Stutz and let you hear about his important work in this area. Thank you.
Thank you very much for the opportunity to present to everyone today. So I'm going to be talking about a program of research very quickly in 3 different areas, highlighting some of our work in screening, survivorship, as well as social change around the concept and the challenge of lung cancer. You have a couple of conflicts or potential perceived conflicts that I want to acknowledge, but I think this is a slide that indicates that I'll work with just about anyone who wants to work with ending the burden of lung cancer. And sometimes that comes in the form of collaborations with industry partners, sometimes funders, and sometimes community organizations. Before I dig too far into addressing challenges, I think it's really important to understand just how much lung cancer care is changing. This is the most recent American Cancer Society Cancer Facts and Figures report from 2022, and it shows stark, exciting, exhilarating improvements in the epidemiology of lung cancer that's being changed by our care. By what we are doing is impacting outcomes in terms of continuing to see a decline in incidence, both for men and women, improvements in mortality, changes that are unprecedented. We've never seen this before. And then the survival rate from individuals being diagnosed has breached 20% for the first time. Now, that is a real glass half full, glass half empty kind of a situation, because frankly, I'll monitor my language, but it stinks. 22% stinks, but it's a whole heck of a lot better than the 13% that I experienced when I started my career. And this changes over just in the past 5 to 10 years, where we've seen these changes emerging thanks to new therapeutics. In many ways, it was the only thing of note in this entire report. And so I redubbed this Facts and Figures report the Lung Cancer Good News report, just because it was so worthy of optimism and hope that are critically important to things I'm going to talk about next. But before I go on to the next step, I want to ask you to take just a second to think about the phrase lung cancer, and to think about the first 2 things that you think about when I say the word lung cancer. Now, I want you to hold them in your head, unless you're experiencing short-term memory loss or perhaps cognitive overload. You may need to write them down, but if you can think of them and just hold them in your minds for a little while, I will come back to that in a little bit. So I moved here 3 years ago after spending much of my career in Kentucky, both at the University of Louisville School of Medicine, the Brown Cancer Center, and the University of Kentucky College of Medicine, Markey Cancer Center. And Kentucky is pretty much the epicenter of lung cancer in the entire world. We were, at the time when we started some of our work, we were number 1 in adolescent smoking rates, number 1 in adult smoking rates, number 1 in lung cancer incidence, and number 1 in lung cancer mortality. And you can see that area over eastern Kentucky and most of Kentucky in reality, the deep, deep red burgundy type of color, really indicating that it is the epicenter of lung cancer incidence and mortality in the entire world. And we don't do screening very well. Kentucky is not what you would think is a very healthy state, although some of these numbers may surprise you to know that we're 27th in colorectal cancer screening, being up to date on that, 29th in breast cancer screening, and 26th in cervical cancer screening. All in all, that's not bad for a state like Kentucky, where you would think the socioeconomic burden and other challenges really drag us down quite a bit. And so we're kind of in the middle of the pack, but in nowhere are we ever exceptional across any kind of health domain. So in following the publication of the National Screening Trial in 2011, we quickly adopted policies to support implementation of lung cancer screening using low-dose CTs, but those were fraught with challenges. Implementation has been a real pickle, to say the least, in terms of really translating this level one evidence from a randomized clinical trial into community settings. And these are just some of the challenges that we're faced, let alone the burden of COVID. And really what we thought we needed was a systematic effort to help low resource settings, or really all settings, but with an emphasis on low resource settings, because remember that I don't have time to talk in detail about this, but there's a disproportionate burden of lung cancer that receive care and have access to low resource healthcare settings. So urban settings with low resources, as well as rural settings with low resources, are where individuals who are at risk for lung cancer or diagnosed with lung cancer receive their care. So I launched the Kentucky Leads Collaborative with a grant from the Bristol Myers Squibb Foundation, as one of the major goals is to help facilitate implementation of high quality lung cancer screening in Kentucky. And the system was a quality-based system, not a quality metric in the sense that we do, 80% of our patients get mammograms in a timely manner or something like that. That's not the kind of quality we're talking about. We're talking about the processes and procedures of delivering lung cancer screening in a robust and high quality manner. So we developed an index where we go and evaluate these programs and provide them a feedback with a report, as well as pair them with a resource portal we've developed to help them integrate best practices and other evidence-based practices into their routine. And we hope to see improvement in quality along that continuum. So we defined quality implementation of lung cancer screening not only to be getting the radiology right and the eligibility and having a multidisciplinary team as best as possible, but lung cancer screening is a platform where we can work on risk reduction. Rather than it being a competition between smoking cessation and lung cancer screening creates another opportunity to implement high quality and empathic and evidence-based tobacco treatment, but also creates an opportunity and brings value to talk about other risk factors like radon and secondhand smoke. And this is important for a couple of reasons that I really don't have time to get into too much detail. But also we really champion patient engagement efforts and help understand who these individuals are that we're trying to serve and put them at the center of the process, not our fancy CT scanner, not our brilliant thoracic radiologist who can, see a pinhead in a field of hay, but actually the people. And that's critically important because of who these people are. They've been disenfranchised and disengaged from our healthcare system. And we've been systematically mean to them for decades. We've belittled them for continuing to smoke in an effort to think that if we just pressure them more and more, they're going to quit. We know that's foolhardy and actually has a reverse effect on most individuals. We need to support them empathically and compassionately, but that's not our history. And so if we take into account that these individuals are disenfranchised, disengaged, untrustworthy, and now we show up with a fancy new technology to help them, they don't care. They don't want to care. We have to help them and negotiate with them and help them understand and engage with them in a process of understanding who they are and how lung cancer screening could fit into their lives in a way. And that has to be through community outreach, but also engagement and clinician outreach to our primary care clinicians, who are really the folks who start this engine. Skipping over lots of details, our Quills system worked. We showed that at baseline, most of our folks only were receiving about 68% of the quality points that we put together in our system, but over an 18-month period of time, they got up to 80%. There's some areas where they systematically still struggled to offer quality screening that there was a little bit more resource intensive. But I think the most exciting part of this whole initiative is some of the secondary effects of what we were trying to do. Remember, we were trying to bake in and help them understand that they need to be responsible for community engagement, that lung cancer screening programs are really going to be the driver of lung cancer screening in our society. that it really has their responsibility and they accrue their benefits as well as the population health benefits by being engaged. And data from our work with Dr. Stacy Fedowa showed that in 2000, using data from 2020, 2020, Kentucky was actually ranked second in implementation of lung cancer screening. Other than basketball and horses and bourbon, and none of those relate to health. Is an area where Kentucky even scratches the surface of top 10, top 20 and something, and we're number 2. And that's really exciting to be at the top of that based on some of our efforts. But the other piece of that is using 2019 data or 2018 data, also from Dr. Fedowa. You can see here that of the four states that are actually doing lung cancer screening fairly well, you can't see them because it's too small, but the others are Massachusetts, Vermont, and New Hampshire. These are not states that struggle delivering healthcare. I mean, everyone struggles delivering healthcare, but if we're being graded on a curve, these are not places with challenges compared to Kentucky. And literally, Kentucky is the only place in what we would consider to be the tobacco belt or tobacco nation to be leveraging lung cancer screening to the opportunity. Quite frankly, this is the most prideful slide I've ever created in my career, and may be that way for the entire career. That since 2009, using data from the Kentucky Cancer Registry from 2009 to 2014, Kentucky had the dubious distinction, as it always has, of being the leader of late-stage lung cancer diagnosis. A full 80 to 82% of Kentuckians diagnosed with lung cancer are diagnosed with late-stage disease. That is atrocious, embarrassing, awful, and any other pejorative term you wish to assign to it. But starting with our work in 2014, we got to experience this. Just through 2018, we've seen a 10% decline in late-stage lung cancer diagnosis. And this is the first health signal, legitimate health signal, that indicates that we are going to be experiencing declines in lung cancer mortality in the very near future in an order of magnitude that's never been experienced by any other state. And once again, this is only 2018. I've had a peek at 2019, and actually the curve accelerates, but is not ready for review. And so this is a picture of a state and an initiative that's really leveraging the opportunity to change the face of lung cancer in Kentucky. We've recently received additional funding from the Bristol-Myers Squibb Foundation to do an exploring and planning project with our Quill system to identify 2 additional states in the country who will be partnering with in hopes to really leverage this platform and achieve some of those same outcomes. And applying, we'll also be revising Quill's system 1.0 into 2.0, taking everything that we learned with our partner engaged efforts around the first initiative. And then, so part of this process is to identify 2 state partners that are ready for an implementation, statewide implementation project like Kentucky leads and Quills. And so testing your geography, and I can name these, I couldn't have named these. Some states are just brand new changes, but Alaska, Arkansas, Colorado, Mississippi, Nevada, New Mexico, and Oklahoma. What we're looking for are states that are not doing well with lung cancer screening, but also present some kind of additional health equity challenge that might motivate additional support and funding in those areas. And this initial project, with a promise of more substantial funding in the future to do a statewide implementation in collaboration with folks in these 2 states. Okay, switching from our screening work into our survivorship work, we recently, about a year and a half ago, received an R01 building on a platform of lung cancer survivorship. You know, the natural consequence of all this work to change the lung cancer landscape or trajectory is survivorship. And yet we have very few survivors, lung cancer survivors, that have been out in the community until very recently. Anyone know how you used to survive lung cancer? Car accident. Because what would happen is you get in a car accident, you would go to the ER, they would do a CT scan or chest x-ray and find a very early diagnosis. Early lung cancer does not have symptoms. Or the symptoms that it does are often masked by some of the symptoms of smoking or other considerations that these folks are. So now that they're actually surviving lung cancer for different reasons in a much higher volume, we have a need to develop interventions. So if you're not familiar with the life experience of is a lung cancer survivor, it's filled with distress. These are the most highly distressed cancer patients that we see. They have intrusive physical symptoms. You mess with the pulmonary system and you get anxiety and lots of other physical symptoms. These are socially isolated and uncared for individuals. They have compromising health behaviors, leading many of them, data that we have show that 30% of individuals are smoking at the time of diagnosis for lung and head and neck cancer anyway. They're disengaged and disenfranchised from our healthcare system, and they're often have remote access to or lack access to our healthcare system. But then they have these two other barriers that confront them, and those are the stigma and biases that every person holds based on our very aggressive tobacco control efforts, as well as a natural fatalism to understanding that the lung cancer prognosis is not good or has not been good. But our information is not perfused through society. And so we, back in the first funded study I ever was a part of was a study back at the University of Louisville, where we were doing something really exciting. We were actually doing comparative effectiveness research before the term was even used, comparing two psychosocial interventions for individuals diagnosed with lung cancer. But I'm gonna go faster with this because this is embarrassing, frankly. This slide is actually a cartoon of our accrual. And what it shows in the red boxes is our anticipated accrual in order to stay on timeline with our project, and the actual accruals in the blue boxes below. Now, we did make hay out of this project by eliminating the randomized controlled trial, going back to the beginning and listening to individuals diagnosed with lung cancer. But this was a classic academic solution to a person problem. And we were way off with what we were proposing. So we moved and had a new opportunity to do another survivorship intervention. And we basically threw out everything that we knew about survivorship and built a new program that really engages individuals who were diagnosed with lung cancer and what their needs were, how it needed to be framed for them in order to engage a survivorship intervention. We weren't there to offer counseling. We knew that what we were offering was counseling, but what we communicated is support and survivorship, not using terminology that was going to further disenfranchise or disengage them. And I'm not going to talk about all of this stuff here because we don't have time, but we talked to them about lung cancer basics. We helped them manage symptoms. We worked with them to deal with some of the challenges of family and distress, as well as making behavior changes. We allowed them to choose what the intervention topics were. They got like a menu of these things and they chose. If they didn't want to quit smoking, we didn't tell them they had to quit smoking. We said, you know, Mr. Stutz, that's just fine. And we can work on these other things. This was how the accrual went. Now, there was a couple times I want to point out in September of the year when we launched, we actually were exceeding our accrual criteria, our accrual trajectory, but actually we were understaffed. We didn't have enough staff to meet the demand, so our accrual actually fell off over a few years. But by and large, this was tremendously more successful than the previous trial. And this is that feasibility trial was the basis for this intervention that we have ongoing that is going to be launched in the next couple of months in Kentucky, working with rural centers to do a 2-arm parallel group randomized trial of our Kentucky Leads survivorship intervention versus a control condition. I want to wrap up by going back to the societal change piece that I talked about at the very beginning. And literally, lung cancer care has innovations at every step along the way. We have better risk reduction interventions, we have early detection, better diagnostics, better treatments, and better survivorship. But our ability to deliver all this and really optimize, because that's what we're in it for. We here on campus love discovery, but we also have to love implementation and changing real health outcomes for folks. And stigma and nihilism impede our ability to translate our discovery science, our clinical science, into real people. And because there's systematically less efforts made to address lung cancer in these different communities. And I want to call your attention to how many people have read this author, Chimamanda Adichie? Anyone? All right, one, yay. So she also has one of the top 5 TED Talks ever delivered. And honestly, stop listening to me and go listen to her TED Talk right now if you have that opportunity, because it talks about the danger of a single story. She was a woman growing up in Nigeria, moving to the United States for school. You want to tell the story? And basically what coming to the college here, her roommates and her social network all had this belief that she's coming from a place where she was, cooking in wood stoves and had, tribal issues and these things, and dangerous beliefs about who she was based on the color of her skin and her place of origin. And so she calls it the danger of a single story, and really oversimplifying who she was as a human being. Turns out both of her parents were faculty members at the local at the national university, and she grew up quite wealthy and access to resources. But this is sort of a parallel. I've completely stolen this, with appropriate credit, obviously, to the concept of lung cancer as having a danger of a double story. Now, I asked you those two beliefs that you have, or what things you thought of, and I'm willing to bet the majority of you included some belief, some link to tobacco, and then a poor prognosis or death. Now, these are the two beliefs that are prevalent in society. Maybe because we're in healthcare and research, we might have a couple of different beliefs, but these are the prevailing ones. And it makes sense that if you combine a belief about that this is caused by tobacco with aggressive tobacco control marketing telling us you're stupid and you're going to die and you should be ashamed of yourself for smoking, you're going to get a systematic societal stigma. It's like a formula that tried and true. If you understand that for all of time, lung cancer care outcomes have been terrible, and you apply limited attention, social attention, and have isolation and limited research allocations, which has been shown, you get nihilism and fatalism. And together, these two things are prevalent in our society that really have introduce a lot of barriers. So we started the campaign to end lung cancer stigma through the National Lung Cancer Roundtable and some of our community engaged work, with the idea that we could leverage the empathy and optimism being generated by these treatment innovations with a sense of urgency that the time is now to transform how our society thinks about lung cancer, to infuse it with empathy and optimism, and to work on these different themes to really improve care outcomes, improve care delivery, expand the scope of research, and to really support our community more effectively. One of the things that we've done is to develop a language guide, which is with the International Association with the Study of Lung Cancer, happens to be based here in Denver, but to change how we talk about lung cancer. We want to eliminate the term smoker in favor of person-first language. An individual who may or may not smoke, an individual who currently smokes or smoked previously, is a much more respectful and engaging way to think about these individuals. Smoking does not define them, but if we define them as a smoker, we are missing an opportunity to engage and express our empathy and compassion. We have to do this in research settings too, and this is where this started. We need to be much more, many organizations, many of our professional societies are doing a much better job of bringing the community inside our science to have a better impact on it. And if we use the same derogatory, colonial, paternalistic language with these communities, we will isolate them and earn enemies as opposed to partners. And so we've also developed, developing with the funding from the American Cancer Society, what we're calling the lung cancer stigma biopsy. And what this does is it helps content developers, or when they're developing content around lung cancer, around tobacco, to infuse principles of person-first language and other things of language that we want to include, and some things that we want to avoid. Imagery that's supportive and engaging. So many times we fall into these habits. You can see just very demeaning negative messages about smoking that are trying to drive change with fear and bias. We're done with that. That has had an effect, believe me. It has had positive effects on reducing our tobacco use as a nation, but we're not moving the needle anymore with those types of things. We're down to a place where we need to change our path. It needs to be a paradigm shift, and it needs to be empathy and compassion and understanding. That's what's going to move us in the right direction, as well as understanding that there's context around these things that needs to change and be sensitized to. So in conclusion, because I'm already over time, is to despite historical underfunding of lung cancer research, recent innovations are transforming care and outcomes. There's not many times when you really see, stark transformations in care, and yet that is what the lung cancer care environment is. I mean, there's been 37 or 38 new drugs in the past 5 to 8 years. That's incredible. The FDA makes an announcement on a new drug every month. Translating these innovations into routine care has been complicated and suboptimal. People are not getting these new tools. And I hope that discussed you as much as it discussed me, because that's why we did this. Discovery without translation is nothing. There's an acute need for comprehensive and multi-level efforts to improve lung cancer screening to get this process started, and we're working on that. The natural consequence of these innovations is more survivorship, individuals living longer and having to worry about the late and long-term consequences of their diagnosis and treatment, and we have to be there for that. We have to be on the cutting edge of supporting these individuals. Talk to my oncology colleagues, they get to go, some of these folks get to go back to work. Nobody went back to work following a diagnosis of lung cancer before. It's not happening. We need to know how to help them do that. And also at the societal level, the persistent stigma and nihilism and fatalism have impeded our progress and have toxic consequences that simply must be remedied if we're going to be able to support these. And this is not only just a warm, fuzzy kind of thing, but thanks to Mark here, I can mention health economics. This can improve the outcomes of our healthcare system and the cost effectiveness of what we're doing, if we're able to engage people in these effective interventions, but we have to reach them empathically, compassionately, and supportively. They are humans. Thank you.
Question, there might be time for one more question. We're running a little bit behind. The intervention with QALY that you did in the rural healthcare settings, how did you implement that? Because you say rural healthcare settings, but that's many different types of organizations and models and administratorships and so on. So could you just speak to that?
So at Kentucky, we were very fortunate to have the Markey Cancer Center Research Network, which was an affiliation of a whole bunch of other cancer care facilities that once we were designated an NCI designated cancer center, they really wanted to partner with us. But also the University of Kentucky has a long history of working with rural healthcare delivery services. Heck, we trained most of them. They most have passed through our fellowship program. And so we developed these relationships and then created platforms and opportunities. But perhaps the most important thing is we didn't even design for dissemination. We designed for acceptability and feasibility, meaning that the interventionists that we trained to do this were whoever they said the interventionists were, not who we wanted, because they simply weren't going to have a licensed clinical oncology social worker at every one of these facilities, or a psychologist or a psychiatrist. And many of them didn't even have advanced practice nurses that specialize in oncology. They told us things, and we followed their lead on many of these things. And so, yeah, we would as a clinical health psychologist, would I like to have a licensed health psychologist delivering these interventions? Of course, not realistic. And so we really designed it to be able to be conducted in those settings, and had the history of relationships that we had developed over time.
What else have a question?
The improvement in survivorship. Did you take a deep dive into the data? Is that all lung cancers, including small and not small cell, or oncogenic drivers or anything like
Nope. No, we don't know any of that business, because we sometimes our cancer registry data aren't as robust as we would like to some of these new parameters, but really that was all stage, all diagnosis. So actually we're hampered by that because we're not really going to do as much as we'd like to be able to do with small cell. And so the fact that we're seeing these changes is exciting.
Thank you very much.